Pediatric cataract surgery presents a unique challenge for all ophthalmologists, a challenge which, if overcome with success, ensures great sight and great life for your young patients. So it becomes our duty as pediatric cataract surgeons to maximize the outcomes while operating a pediatric eye for cataract. Pediatric cataract surgery often is underestimated, like in this case, as a walk in the park. This video hopes to provide those 10 tips that will ensure success in achieving this, with a special note to maximizing outcomes in difficult situations that may make you shiver in the OR. My first and foremost tip is about the choice of anesthesia. Sit with your anesthetist and choose the wisest choice as per your experience, surgery time and patient vitals. Beginners, interview it and give muscle relaxant. Don't forget about head positioning and shoulder support. Choose to your comfort. My second tip is dilating your pupil. You may follow atropine dilatation pre-op and patching, but to ensure a good pupil size, use intracameral adrenaline in the dilated form. Some cases of the small pupil may require devices, iris hooks, and sometimes when there is no or minimal space, mechanical stretching does the job. My third tip on staining, a simple yet very effective tip, is to stain after making your essential corneal wounds. That way, not only is your capsule better visible, so is your incision. My next tip is about choosing your rhexis technique. My obvious choice is the AIOC2023 forceps, which enables a good controlled rhexis while forces aim with pull towards center along with grasp and regrasp wherever needed. You may use the push and pull technique as described by Dr. Nishchal, or the micro-rhexis forceps from the side port in very young children where you may not plan for an IOL. Vitrorhexis also is a handy technique when planning a lensectomy. Often a challenge like traumatic cataract in these cases ensures creativity in your OR. My next tip is on lens aspiration. Practice pulling your cortex from the periphery before aspirating the central nucleus. This enables you to be prepared when a central rupture may be hiding. My sixth tip is about posterior capsular rhexis, a very necessary step in all pediatric cataracts, especially if you want to avoid the uncomfortable amblyopia situation after surgery. Underfill the AC with visco to enable your posterior capsule to come up. Take a small nick, fill the Berger space with OVD, and using your favorite method, make a sufficient circular capsular opening. My seventh tip is about anterior vitrectomy. The aim is to clear and prevent any scaffold for visual axis opacification. The endpoint under controlled parameters should be margins to fall back without any peaking. Top tip is to go under the margins 1 to 2 millimeters and clear the vitreous there too to prevent PCO in the future. My eighth tip is about inserting the IOL. Prefer an in-the-bag implantation with a single piece by imagining an aeroplane landing. Enlarge your incision adequately before starting. Let the leading haptic dip, and once just before the pupillary area, plan to direct the leading haptic upwards to establish an in-the-bag implantation. The art of handling a 3-piece IOL should be mastered for all difficult situations. My ninth tip is to prepare for the worst. Plan a VR backup and counsel for aphakia and secondary IOLs, more so in cases which may have their own special challenges. That way you ensure maximum outcomes in one general anesthesia setting. 10th tip is to plan for the future, not always take it to heart or a matter of skill. It's okay to plan for a secondary IOL when it's the best possible way forward for the child. Remember to clear the visual axis opacification and start amyloid therapy as soon as possible. Hope these 10 tips help you maximize your outcomes, because these little folks need special strokes. Thank you.